Welcome to this presentation on causes for acute red eye. Learning objectives include going over basic anatomy of the eye, systematically working through causes of acute red eye, and recognising common emergencies and knowing when to refer. So we'll start off with some anatomy and then progress through the eye layers and finish off with acute angle closure glaucoma. So looking at the eye, you've got the conjunctiva, which is the most superficial layer of the eye. You've then got your cornea, which is your clear window of the eye. Behind that, you've got some aqueous humour, and then you reach the iris, the defect in which is the pupil. Posterior to that, you've got your lens with the suspensory ligaments and the ciliary bodies. You've also got your sclera around the outside of the eye, which is visible and also extends towards the back of the eye. So starting off with eyelid disorders. So we'll start off with a stye. This is basically either an infected hair follicle at the base of an eyelash or an infected oil gland. It can be caused by staphylococcal infection, and symptoms would be discharge, swelling of the eyelid, and a watery eye. So management of this is with topical antibiotics and the use of hot flannel massages. So the way that this works is you put a hot wet towel essentially over the eye and slowly massage it, and this helps express out that discharge and relieve the pain associated with it. You can also get blepharitis, which is inflammation of the eyelid itself. This can be caused by staphylococcal infection or by seborrheic dermatitis, and it's quite often a chronic condition that patients have to manage over the long term. Symptoms-wise, you can get sore, gritty eyes, itchiness, burning, and sticky eyes. And as you can see in this picture, you can see some discharge at the bottom of the eyelashes. In terms of management, if you think there's an acute infection going on, then you need to give topical antibiotics for it. But otherwise, chronically, it's more about eyelid hygiene, using the hot flannel massages, ensuring that you don't share towels with other people, and also the use of artificial tears to help with the sore, gritty eyes. So moving on to the next layer of the eye, the conjunctiva. So this can also get inflamed. It's very common to see in children and in adults, and you can get viral, bacterial, or allergic conjunctivitis. So viral conjunctivitis is most commonly caused by adenoviruses, by herpes simplex, or by varicella zoster. Bacterial infections can be caused by Staphylococcus, strep, or Haemophilus, but chlamydia and gonorrhea are important pathogens to know about. This is because you can get conjunctivitis associated with STIs, and also with newborn babies if the mum has got an undiagnosed STI and has a vaginal birth. You might see a baby present with conjunctivitis, and it's important to rule out chlamydia and gonorrhea as a cause of this. You can also get allergic conjunctivitis, so this will present with symptoms similar to hay fever, and they might either have it seasonal or it might be perennial, so throughout the whole year. So signs and symptoms of this will be having a red eye, generalised redness, not really localised to one area, and often it's bilateral. It might start as unilateral, but often when people, especially children, rub their eyes, they can transfer the pathogen across to the other eye. It causes irritation, grittiness, and discomfort, but it doesn't really cause pain. So if you've got someone with these sort of symptoms and it's causing them pain, you need to be thinking of an alternative diagnosis. Viral conjunctivitis will give you a watery sort of discharge, but the sticky purulent discharge that you can see in this image is much more likely to be a bacterial infection. So for bacterial infection, you can give chloramphenicol drops. Those are just simple antibiotics that will help deal with the infection. For viral conjunctivitis, it's usually self-limiting, so just give supportive management. In both of these conditions, it's important to talk about hygiene, so no sharing of towels between family members to prevent further spread of conjunctivitis. So moving on to episcleritis and scleritis. So the sclera is the next layer that we encounter. Episcleritis is inflammation of the superficial part of the sclera. So this is a common benign condition, and there isn't really much to do in terms of management. It's more supportive. However, scleritis is severe ocular inflammation, and it's likely going to need systemic treatment, which is why I've put a red star by it, because it's quite a serious condition. So scleritis is what I'll continue to talk about mostly. So you can divide scleritis into anterior and posterior. So anterior is the part that you can see when the eye is open. Posterior scleritis affects the back of the eye. Most cases of scleritis are anterior, and those can be divided into necrotizing and non-necrotizing. Non-necrotizing is the most common, and it's this type of inflammation that you see in the picture, so diffuse anterior. Sometimes you can get a localized area of inflammation, but the diffuse anterior is much more common. Scleritis is often seen in association with other inflammatory diseases, such as rheumatoid arthritis, SLE, reactive arthritis, and ankylosing spondylitis. So it's important to take a thorough, systematic review history when you're seeing these sort of patients. So typical signs and symptoms that you get your red eye. With scleritis, patients often say that it's a very severe drilling sort of pain. It's like someone's boring into their eyes and the pain is radiating through the orbit. It can also radiate to their forehead, to their brow and their jaw, and the pain might be so severe that it wakes patients up at night. They can also get associated watering of their eyes, photophobia, and a gradual decrease in vision. Because this is an infective course, you won't get the discharge with it. The reason that scleritis is such a worry is because its complications are quite severe. So if you imagine you had the anterior redness, the erythema, that part can become ischemic if left untreated, and that can lead to blindness. You can also get raised intraocular pressure and retinal detachment as a consequence of untreated scleritis. So for non-necrotizing anterior scleritis, which is the most common type, you initially start treatment with oral NSAIDs. If this doesn't work, you can step treatment up to oral prednisolone. If you get scleritis as part of a systematic autoimmune disease, you might need to consider some more generalized immunosuppressive therapy, such as methotrexate, azathioprine, and oral cyclophosphamide. For necrotizing anterior scleritis, which is much less common, you need to start oral steroids and immunosuppressants as soon as possible to prevent further damage to the eye. Next, moving on to the cornea, you can get corneal abrasions and foreign bodies within the eye. So typically a patient might come up and say that they've got a red watery eye and it feels like they've got something stuck in their eye. On examination, you might see conjunctival injection, which is the redness of the conjunctiva, and if you've got a metal object in the eye, there might be a surrounding rust ring, as you can see in the picture on the left-hand side. Sometimes it might be that when you look in the eye using just the naked eye, you can't actually see a foreign body. That's why it's important to use a slit lamp and dye to have a look at any corneal abrasions. As you can see in the picture on the right hand side, you've got some scratching marks on the cornea, and actually if you were to invert the upper eyelid, you'd be very likely to find a foreign body that's stuck underneath there. So every time the patient blinks, they actually cause further abrasions to their cornea, and if you don't invert the eyelid, you would never find that foreign body. So the reason that we get worried about corneal abrasions and foreign bodies is because firstly you can get superimposed bacterial infection, but also if you've got someone that's been using high-powered drills and not been using adequate eye protection, there's actually a chance that they might have perforated their globe. The risk of this goes up if you can't see any foreign body when you look in the eye, because it actually suggests that the foreign body has gone through the layers of the eye already. In these cases, you need a CT scan or a B-scan ultrasound to exclude an intraocular foreign body. In terms of management for these patients, you would give topical local anaesthetic and then try and remove the foreign body along with any surrounding rustering. The way that I've seen this done is an eye casualty, where either a cotton wool is used or the tip of a needle. It's really important that you remove the rustering as well, even if the patient has to come back on a separate day for this, because the cornea might not heal properly if the rustering is not removed. You'd also always cover these patients with topical antibiotics to make sure that they don't get a superimposed infection. Next, you can get infection of the cornea itself. So we'll start by looking at bacterial keratitis first. So this has your typical features of pain, photophobia, and as we start moving further back in the eye, we start getting symptoms like reduced visual acuity. If you use fluorescein dye, you might be able to see a visual defect within the eye as well. So either a bit of loss of the cornea, some ulceration or other damage. You can also see a white cell infiltrate. So if you look at this image, you can see the redness of the eye. You can also see at about 8 o'clock on the eye, there is some whitish opacity, and that is a white cell infiltrate, which is just the inflammatory response essentially. So risk factors for bacterial keratitis, the biggest one are contact lens wearers, especially those who wear contact lenses for prolonged periods of time and who may not have adequate hygiene when talking about their contact lenses. You can also get bacterial keratitis as a consequence of prolonged steroid therapy, or if you've got a poor tear film. So this is important in patients that can't close their eyelid for various conditions. You need to make sure they've got eye protection, they've got artificial lubrication, otherwise they're at risk of bacterial keratitis. Viral keratitis can also give you a superimposed bacterial infection, as can having diabetes, because you have poor wound healing. So management of these patients, you need to do a corneal scraping and send that off for MCS. In the meantime, you'd start intensive broad-spectrum antibiotic drugs. You'd also use dilating eye drops, so cycloplegics. The way that this works is because when the cornea gets inflamed, the ciliary muscles also become contracted and can cause pain. So by relaxing those ciliary muscles, you help to relieve some of the pain. In terms of topical steroids, this is really a practitioner by practitioner decision. So some people do like to add in some topical steroids during the healing stage because it reduces corneal scarring. However, it can also prolong the course of the infection and actually make it a little bit tougher to treat. If you've already tried antibiotic drops and the keratitis is non-responsive, it's a good idea to send off a further scraping and try some antifungal treatment in case this could be fungal keratitis. So looking at viral keratitis next, the most common causes for this are your varicella zoster, so your shingles, or herpes simplex virus. So you get the pain, the photophobia, reduced visual acuity. If you've got shingles, you will get a dermatomal rash in the first branch of the trigeminal nerve of CNV1. If you get Hutchinson's sign, this is where you get a dermatomal rash, characteristic of shingles, but at the tip of the nose. So there's good evidence to suggest that if you have the presence of Hutchinson's sign, you've got a very high chance of getting viral keratitis. With herpes simplex keratitis, you might not get any skin lesions, but actually when you look at the eye using a slit lamp and using some dye, you get characteristic tree-like ulcers, as you can see in the picture on the left-hand side. These are called dendritic ulcers because they look like trees, and the reason we worry so much about viral keratitis is that both varicella zoster and herpes simplex can cause damage to all layers of the eye. So in terms of management, For herpes simplex, you can just use topical antivirals and add steroids if necessary. However, for varicella zoster, you need oral antiviral treatment. In both of these, you can do cycloplegic drugs as well, and they would work for the same reason as we covered in bacterial keratitis. And it's often a good idea to give topical lubricants as well, because these patients are likely to have quite dry eyes. So in terms of triggers for viral reactivation, no one's really sure why the virus does get reactivated, but some common theories are UV light, trauma, menstruation, and stress. So then moving on to the iris, so anterior uveitis is where you can get inflammation of the iris. If it's unilateral, it's more likely to be an infective cause, but if it's bilateral, you need to be thinking of a systemic condition that is causing that. It's associated with HLA-B27, with ankylosing spondylitis, with Behçet's disease, and with reactive arthritis. So signs and symptoms, you can get the red eye, and interestingly enough, here you've got some injection of the eye, so the redness, but actually with anterior uveitis, it's mostly around the iris, and that's called perilimbal injection. This is in contrast to conjunctivitis, where the redness actually starts laterally and moves inwards. You'd also get photophobia, reduced visual acuity, and an associated headache with anterior uveitis. On examination, you have the perilimbal injection, as we've mentioned. When you look through with a slit lamp, you can see cloudiness of the aqueous humour, and you can also get a hypopion. This is where you have a fluid level because of white cells which collect in the anterior chamber, and it's visible on the bottom photo as a fluid level at the bottom of the eye. You can also get keratitic precipitates, which are collections of lymphocytes, and then you can get synechia. So these are basically attachments of the iris, either anteriorly to the trabecular meshwork or posteriorly to the anterior lens capsule. So if you think about it, the iris is what actually controls the pupil size. In the bottom picture, the iris has actually gotten stuck either behind or in front, and because it's got stuck, you've got a distorted pupil. So complications of anterior uveitis, you can get raised intraocular pressure. This can be because of steroid treatment, because that's how you treat anterior uveitis, or it can be because of a condition called iris bombée. So this is where you get 360-degree synechia formation. So if we have a look at this diagram, on the left-hand side we've got a normal eye. So you've got aqueous humour being made where the green arrow is, behind the iris. It then tracks forward through the pupil and then will turn on itself and get drained in the iridocorneal angle via the trabecular meshwork into the canal of Schlemm. On the right hand side, you've got this condition called iris bombée. So we've got the lens, which is in brown. We've got the iris, which is in brown. We've then got a posterior synechia, which is highlighted in yellow. So here you've got the iris, which is stuck to the lens posteriorly. This means that aqueous humour can't drain out, which is where your red arrow is. So because it can't drain out, your iris starts ballooning forward, so bowing forwards basically, and that means that your iridocorneal angle is much reduced, and therefore aqueous humour can't drain away properly. This leads to a gradual increase in intraocular pressure, and this can cause damage to the optic nerve if left untreated. With chronic uveitis, you can also get formation of cataracts and macular edema. In terms of management of these patients, you need to give them cycloplegic drugs. So these are drugs that dilate the pupil and help break synechia. So if you can imagine where the brown iris is, if you imagine that gets fully dilated, so it pulls away, you actually won't get the formation of synechia, so you won't get this problem of aqueous humour drainage. You also need to treat patients with steroids. So this starts with intensive treatment. So every 1 to 2 hours they have to put drops in, and then gradually you taper that down. If someone's got bilateral anterior uveitis, or they've got recurrent uveitis, you need to be thinking about working them up for a systemic autoimmune disease. So this would include doing a full blood count, an ESR, an ANA, and chest X-ray and urinalysis for completion. So lastly, going on to acute angle closure glaucoma. So this is one of the different types of glaucoma you can get, but it's the one that we treat as an emergency because the pressure rises so quickly within the eye that actually the body doesn't have time to adapt, and therefore you can get severe damage to the optic nerve. So risk factors for acute angle closure glaucoma are being a severe hypermetrope, i.e. being very long-sighted, having age-related lens thickening, and formation of synechia. So if we have a look at this diagram here, you've got the lens, you've got the iris, and you've got the cornea. You get aqueous humour being made where the green arrow is, and then coming forward through the pupil to drain by the iridocorneal angle. So if you're a severe hypermetrope, the way that your eye is shaped means that it's actually much wider. So your iridocorneal angle naturally is much shallower, much more acute, and therefore more likely to get blocked off. If you've got age-related lens thickening, as the lens gets fatter and fatter, it then pushes the iris up further and then closes the iridocorneal angle. And formation of synechia we've covered already in the previous slide. So typical signs and symptoms that a patient might come into you with will be having severe periorbital pain, having a headache, reporting blurred vision with classically halos in their vision, and being systemically unwell with nausea and vomiting. So interestingly, a lot of patients say that this comes on in the sort of mid-afternoon evening time. And the reason for this is as it gets later in the evening and it gets darker, the pupil will start to dilate. As it does so, the iris contracts backwards and it can sometimes get stuck on the lens for some reason. As it does so, it then stops the drainage of the aqueous humour, and then you get that raise in intraocular pressure. On examination, you'll get a non-reactive or a very minimally reactive pupil on a closed iridocorneal angle when you have a look via the slit lamp, and a raised intraocular pressure of more than 21 millimeters of mercury. In terms of managing these patients, they need urgent admission to a hospital. They need to be given systemic ocular hypotensive medication. So this is something to reduce the pressure within the eye. And often it's IV acetazolamide, which is then converted to oral. You can also try IV mannitol. In addition to this, you give patients topical pilocarpine drops to constrict the pupil. So if dilating the pupil started off the glaucoma, it makes sense that if you constrict it, as your iris moves back towards the midline, your iridocorneal angle starts to open back up again and you get drainage of the aqueous humour. You can also use standard intraocular pressure lowering drops. So these would include your beta blockers like timolol, your prostaglandin analogues like latanoprost, and alpha agonists. Often these patients will need systemic analgesia and antiemetics as well, because they will be feeling quite unwell in themselves. Long-term management of these patients would be a laser iridotomy or a surgical peripheral iridotomy. In both cases, you get formation of small holes within the peripheral parts of the iris, either with a laser or during surgery, and this offers an alternative pathway for the aqueous humour to then get drained, so going from behind the iris to in front of the iris, and make sure that they don't get such episodes again. Even if they've only had the episode in one eye, you would still treat both eyes because they are equally at risk of having a second episode in another eye. So that's the end of my presentation. I've included a list of the images that I used, and in terms of useful resources for ophthalmology, patient.info is very good at covering signs and symptoms, diagnosis and management. Oxford Handbook of Clinical Specialties gives you a good overview of each condition, And the College of Optometrists has its own guidelines, which are quite useful when looking at how urgently a patient needs to be referred or not. Thank you very much.